Hello, everyone, and welcome to the webinar, Understanding and Responding to the Emerging Behavioral Health Needs of Military Drone Operators, sponsored by SAMHSA service members, veterans, and their families' Technical Assistance Center. My name is Xavier Robinson, and I'm a Director of Practice Improvement at the National Council for Behavioral Health, and I will serve as your moderator for today. Before I begin, I'd like to draw your attention to some important webinar logistics. During today's presentation, your slides will be automatically synchronized with the audio, so you will not need to flip any slides to follow along. You will listen to the audio through your computer speakers, so please ensure that they are on and the volume is up. You may send us questions at any time during the webinar by typing your question into the Ask Question box in the lower left portion of your player. Depending on the question, we may type an answer back to save time or save it for the end. We'll answer as many of your questions as time allows. This webinar is being recorded, and an audio version of the entire webinar, as well as a PDF of the presentation slides, will be available on the Webinar Archives page of the National Council's website within 48 hours of this broadcast. Following the webinar, we invite you to please complete a short survey. Finally, if you need technical assistance, please click on the question mark button in the upper right corner of your player to see a list of frequently asked questions and contact info for tech support. I'll now pass things off to Catherine Power.
Well, thank you very much, and good afternoon. If you're on the East Coast, it's good afternoon. If you're on the West Coast, it's good morning. I want to welcome everyone to this webinar. We've had a lot of interest in this webinar, and I know that it's indicative of not only our own curiosity about what is happening with these operators from a behavioral health perspective, but also because it's really a lot of new emerging information. And so we're very fortunate to have the panel of presenters that we have today. For those of us at SAMHSA, this has been a consistent labor of love for us to pay attention to this population. We started looking at this population back in 2005 when many of our grantees across SAMHSA began to tell us and report to us that either they themselves as grantees were encountering individuals or family members of returning veterans who were struggling back home in their communities, particularly around some of the behavioral health issues. And so SAMHSA decided to begin to take a look at this and to say internally, what could SAMHSA do? We are a small agency. We have really no authority and no appropriation that Congress tells us to pay attention to this population, but we began to understand that there were many people who may or may not be using VA services. And so we started internally to get ourselves smarter about the kinds of behavioral issues that veterans and their families were facing, and we began to understand that we needed to bring more visibility to this. In 2010, we created a special strategic initiative for this population, and then last year, after 5 years of very focused attention in the creation of policy academies across the states, in the creation of special topic trainings, in the creation of our TA Center, we have now embedded the work with this population into SAMHSA's everyday programs, into special populations under our grants, and into an overarching awareness that this population has to be visible, cannot be forgotten, and that the civilian community has a tremendous responsibility, and we need to continue to nurture that sense of ownership across the military and civilian communities and to cross the military-civilian divide. And we have enormous opportunities to do that at the federal level. SAMHSA represents the entire Department of Health and Human Services at the federal agency level in work that we do directly with the Veterans Administration and with the Department of Defense. So there is ongoing collaboration on a weekly basis between HHS and SAMHSA, other component parts of HHS, and VA and DOD. We do an enormous amount of collaborative and partnership work with them, and we have continued over the last several years to help to build the state policy teams and build their capacity, their leadership, and their capability to look across their local and state and regional level responses and make sure that we're connecting the VA resources that are available, the civilian resources that are available, community-based organizations, and community-based collaborations, along with the active duty components that may be in a state, along with their National Guard, along with the reserve component units, along with VA medical centers, along with vet centers, along with a host of VSOs, all of those organizations tied together in a very strategic way to ensure, one, that this population stays visible, two, that this population may have emerging behavioral health needs over time, and three, to make sure their outreach and engagement connects both military service members, veterans, and their families to whatever resources are available. So I'm delighted to welcome you to this webinar and to thank you for caring about this population. And I am pleased to introduce a stellar team of presenters. Our first presenter will be Angela Wright. Ms. Wright is the Assistant Project Director for SAMHSA's Service Members, Veterans, and Their Families TA Center, which is housed at Policy Research Associates. Ms. Wright is a U.S. Air Force veteran, as well as a spouse and caregiver of an Operation Enduring Freedom, Operation Iraqi Freedom combat veteran. Her areas of interest include military and veterans health policy and the psychological effects of combat. For the past 3 years, she has led and managed a diverse set of service members, veterans, and their families projects that are related to the interagency collaboration of all of our state teams. She has her JD degree, and she has an enormous amount of experience as a person and as a professional and as a lawyer and as our associate director at our TA Center. Our second presenter is Dr. Wayne Chappell. Dr. Chappell is the United States Air Force Surgeon General Consultant and Team Leader for Aeromedical Operational Clinical Psychology. In fact, he has over 20 years of experience developing psychological screening, occupational health, and performance improvement programs. His experience as a military psychologist includes deployments to Southeast Asia in support of Operations Enduring and Iraqi Freedom, and serving as commander of installation outpatient mental health clinics for the United States Air Force and the United States Army. He has over 60 publications in national and international peer-reviewed journals and technical reports. And our third presenter is Mrs. Lillian R. Prince. Mrs. Prince is the program manager for occupational health research for the Air Force School of Aerospace Medicine, as well as a Colonel Select and Career Intelligence Officer in the Air Force Reserve. She has served at the squadron, wing, group, major command, and joint level, both as an active duty and reserve officer, with unique experience in signals intelligence, information operations, and anti-terrorism analysis. Both of our presenters have had enormous levels of educational experience across both the civilian community and the military community, and I ask that you read their extensive bios that we offer to you in the materials. So I want you to welcome this stellar presenter team, and on behalf of SAMHSA and the TA Center, I'm going to turn it over to you, Angela.
Thank you, Catherine, so much. I really, as always, appreciate your advocacy and support for this population there at SAMHSA, and I'm really glad that you were able to join us today for this webinar and kick us off. I would like to take a moment to set the stage and tell you a little bit about our organization and why we felt this topic was so important. Next slide, please. The TA Center has been a dedicated staff that's been working since about 2010 to strengthen ongoing collaborations among state and territory level military and civilian stakeholders. We provide a centralized mechanism for states and territories to learn, connect, and share. We really are interested in increasing awareness and access to resources and programs and making sure that we're all working together to strengthen behavioral health systems for our service members and veterans and their families. We really try to support coordinated responses and encourage states and territories to implement promising best practices and evidence-based practices. Next slide, please. The TA Center works to provide support to interagency teams that Catherine had referenced earlier in her introduction. These teams were formed to work together to address the behavioral health needs of our service members, veterans, and their families. We provide technical assistance activities like policy academies where we bring interagency teams together to form strategic plans. We do implementation academies where we bring delegations together to drill down on a specific topic and create an action plan to implement best practices. We also have virtual learning opportunities like this webinar, and also learning communities where we bring smaller groups together on a virtual platform to learn together and to share. We also lastly provide site visits where we go in person with our teams and meet together on individualized problems and help them connect with subject matter experts and make sure that they can implement their plans in their states and territories. And lastly, we have a robust materials of resources like fact sheets and our newsletter, Topics in the News, that we disseminate out to the world to make sure that everybody is in tune with this population and their behavioral health needs. Next slide, please. So why did our TA Center choose to highlight this topic? Well, we know that this is a growing career field, and we know that there are some unique challenges that we should all be aware of. We have information that the number of strikes by Air Force remotely piloted aircraft has greatly increased in the recent years. For example, from January to October 2016, there were 2,473 strikes. That's 12 times the number of strikes from 7 years ago. And the use of RPAs, or drones, is expanding to the Army and the Navy and the Marine Corps. So this is a really growing career field, and that means that there are people out in our communities who have worked in this career field and who are family members of these operators that will need our support for their behavioral health needs. We understand that there are unique behavioral health risk factors associated with RPA operations, and we need to take the time to learn about their unique needs to help us better support them as a population in whole. And that's why I'm really excited to turn this over to Dr. Wayne Chappell, and he's going to share all of his depth of knowledge on this subject and give us some great insights that we might otherwise not have known. Dr. Chappell, would you like to take it off?
Sure. Thank you very much, Angela. I appreciate that, and thank you for the introduction. Okay, so let's go to the next slide, slide 12. And what I plan on doing is sharing with folks out there information that we've collected over the last 7 to 8 years in which we've spent a lot of time with drone operators. And when I speak about drone operators, I'll be referring specifically to Predator-Reaper operators. And I'm going to distinguish what those individuals are and what they do a little bit later on. But before I begin, one of the things that I want to mention is that the data that we collect is very unique. It's very different. I think as folks know, when you work in an environment that is surrounded in classified operations, it's very difficult to obtain very accurate mental health data. Because a lot of times what happens is that people who do report, it only represents a select group. And so what makes our research very different is that we don't wait for people to report to the medical clinic or a mental health clinic. We actually go and spend time with them in their operational environment, and we screen large percentages of individuals to ensure that we're getting an accurate idea of what the prevalence rates are of certain mental health conditions. So our research is very different. It's not just simply mining existing medical and mental health records. Okay, next slide. So what I'm going to do is share with you the highlights from our previous research, which will get into rates of exhaustion, psychological distress, relationship difficulties, and so on. But I'm also going to do a deeper dive into our analysis and what we've done with our interviews of looking at people and evaluating pre-post weapon strike psychological reactions. And I'll cover the range and breadth of emotional reactions that people have as they engage or prepare during and after they've engaged in a weapon strike. And what's interesting about this is that there's typically no shortage of strong opinions or perceptions that people have about how people react when they're directly involved in a weapon strike. And hopefully today, with the information I'm going to give you, you'll be equipped or better prepared to understand the kaleidoscope of reactions that people typically have. And then from that, I'm also going to share with you the recommendations that we've suggested to medical providers as well as line leadership. And when I refer to line leadership, line refers to military commanders. Okay, next slide. What people may not know is that the term drone is used quite frivolously. It's used, I think, quite loosely in many regards because it's such a growing industry. So when people refer to drones, they oftentimes think about these small remote-controlled aircraft that you might be able to buy off of Amazon.com. But the drone operators that we're referring to are your MQ-1 Predator and your MQ-9 Reaper aircraft. And you could see the specs of these aircraft on this particular slide. Now, what you may not know is that very few countries actually have RPAs that have weapon strike capabilities. The military has a large inventory, and both civilian industry have a large inventory of different kinds of RPAs and drones. But there are only less than a handful of countries that actually have drones that allow for or have weapon strike capabilities. The MQ-1 Predator in particular was the first one that had weapon strike capabilities, but it wasn't until later on, a few years after the use of the MQ-1, that we came out with the MQ-9. And what distinguishes the two aircraft is that the MQ-9 flies higher, faster, greater distances, and it has a larger weapons payload and weapon configuration. Typically with the MQ-1 Predator, you can slap some Hellfire missiles on that, but with the MQ-9 Reaper, you have a much greater level of arsenal that you can pull from. And that the MQ-9 Reaper has been dubbed the hunter-killer aircraft because it particularly is devoted to those types of unique missions. Next slide. Now, questions come up about what are those medical standards that people have or are required to meet when they go into this particular platform or duty position. And what many people may not understand is that the aeromedical standards, the medical standards that you must meet physically and psychologically for serving as a drone operator are identical to if you were a pilot of a manned airframe. There's no difference at all in terms of the requirements that we hold F-16 pilots to as the requirements that we hold MQ-1 and MQ-9 Predator. And then somebody might also ask, well, what about the sensor operator? Now, the sensor operator doesn't fly the aircraft. They actually control the camera, and you'll say the crosshairs that direct where the weapon would go, or at least target. And the sensor operator actually has to meet standards that are similar to air traffic control. So the bottom line here is that the medical standards that we hold RPA operators to are much higher than typical standard or fitness for duty medical standards for just joining the military. Next slide. So with that being said, I think you should be on slide 16, which is neuropsychiatry standards. And this will reflect to you the fact that simply the presence, or we'll say the absence of illness or injury is insufficient. Simply having a condition that puts you at risk for development of stress puts you at risk and can disqualify you. So let's just say, for instance, you're a healthy, normal individual, but there's something about your psychological disposition that puts you at an elevated risk for the development of adaptation or adjustment-related problems. Simply having that alone can actually disqualify you from participation in drone operations. So our medical standards are very, very high. And when you're in this sort of platform, any kind of potential for subtle performance decrement can be disqualifying. So if you're taking medications for pain management and it's a prescription narcotic, you could not participate in drone operations. You'd actually be disqualified from duty. Okay, next slide. So what have we found? Now what's interesting is that when we ask people what they think the biggest stressors are for drone operators, they often will reflect upon combat-related exposure, because what they do, what they surveil on a daily basis, and the images that they see routinely are pretty powerful. But based upon our research, our engagement, and what we've discovered over the last 7 years repeatedly, is that they will continually cite operational stressors as the biggest issue that's creating most of their stress. And what I mean by operational stressors are the requirements to sustain 24/7 operations with a limited number of qualified people to perform the job. So we have low manning, long hours, constantly changing shift work, and an excessive workload. And what people may not realize is that these are individuals that put on their hat, they go to work, they're engaged mentally in war, and then they have to turn around and have to go home. And so juggling the warfighting role with the domestic role and duties can be very challenging, especially when you're constantly rotating shift work. So for instance, you could be rotating shifts every 30 or every 60 days. And not only is that tough on the body and the circadian rhythm adjustments, but then it's also hard to have a stable home life or meet routinely or reliably domestic obligations and roles. Now what we mean by high role overload and high role conflict is role overload just simply means you have too much to do in the allotted time given, whether it's during the course of a specific shift or the course of a week. And high role conflict means that oftentimes you're tasked with competing requirements. So in one case you may have to fly a mission and surveil a specific area around the globe, at the same time turn around and participate in several administrative tasks and duties. And you'll end up accomplishing one task at the risk of failing to accomplish or meet the requirements of another task. Next slide, slide 17. Or actually slide 18, I'm sorry. Now, here you have 4 particular indices. You have high levels of emotional exhaustion, unreported medically significant psych distress, social role conflict, and interpersonal conflict. By high levels of emotional exhaustion, we mean that these are individuals that are exhausted to the point that by the time they go home, they are mentally spent, and they don't have a lot of mental reserves left over to deal with anything else. Now, that's a common experience I think everyone can relate to, but what we see is when we look at the responses to our occupational health surveys across RPA, our intelligence operators, who are the folks at the back end who are feeding auditory and visual information to our RPA operators, and we compare them with our traditional airmen, which would be security forces, maintenance, logistics, and we compare them with our manned air crew, which could be Aerovac, CCAT, combat search and rescue, maintainers, and so on. What we find is that RPA operators in particular have a higher incident rate of exhaustion, but they also have a higher incident rate of unreported medically significant psych distress. Now what we mean by that is this is a measure we used that allows us not only to look at the frequency and presence of a number of stress-related conditions, but also the severity. And these are individuals who are saying that their stress is so high that it's now negatively impacting social and occupational functioning. And as we all know, familiar with the DSM, everybody can experience some degree of high stress, but it not necessarily be indicative of a disorder until it begins to negatively impact other important areas of functioning. And the people that are placed into that unreported medically significant psych distress category are meeting that criteria. Now, how do we know it's unreported? Because when we go out to these units that operate in these restricted environments, we utilize the same standardized questionnaires and measures you would use if you go into a mental health clinic, and then from that we're able to put cutoffs to determine who's actually meeting the threshold for certain conditions and then who's actually seeking care. Now, high social role conflict and interpersonal conflict refer to relationships at work and relationships at home. And this reflects the percentage of individuals who are experiencing a great deal of distress in those relationships. And I think it's oftentimes indicative of the amount of stress one is underneath. You know, if you're having difficulties getting adequate sleep, getting adequate rest, you're constantly rotating shift work, and you're experiencing stress, oftentimes it's the first place we manifest it is in our relationships at home and work. And this suggests that RPA operators, whether you're doing this full-time or whether you're doing this part-time, to include family members, are at an elevated risk of having relationship problems and difficulties. Next slide. Slide 19. So with that in mind, understanding that operational stressors are a big challenge for folks, especially in terms of the long hours and shift work they have to do, we also recognize that combat-related stress is an issue too, especially since they can see what they do as they engage in the weapon strike, and they have a very clear visual video live feed of during and post-weapon strike. And as a result, you can see a number of different things and be exposed to essentially a wide range of different combat-related activities that can be visually difficult to digest and sometimes incorporate into one's life. Next slide. So with that being said, we actually went out and surveilled people with the PCL-5 to see how many people actually meet, based upon DSM criteria, the number of symptoms across the 4 different areas required for a PTSD diagnosis. So on this slide, you're going to see 2015, it's with the drone operators, and in 2016, we did it with the Intel operators, who are also exposed to a tremendous amount of live feed and visual imagery. And we have the total scores and the percentage of people who endorsed enough symptomology according to the different total score ranges. But what we also did was look at how many people endorsed the appropriate number of symptoms of moderate or greater severity required for a diagnosis. And what we find is between 5 and 11%. And so that might indicate that, yes, PTSD is real, but it's not the level of an epidemic that you might have seen come across certain journal or we'll say news media coverage or certain things that were promulgated by opinion. Ms. Prince and I have repeated this study multiple times, and what we've discovered is it ranges between 4 and 5% for RP operators and really between 11 and 13% for your Intel operators. Now, some people might say, is it even possible to have PTSD based upon the fact that they're not physically there in a combat zone? And the answer to that question is yes, indeed, it is. Next slide. One more comment about PTSD is that if you notice that the triggering event, when you look at the DSM, can actually be through an electronic medium if it's part of your work-related duties. Now this slide, slide 21, speaks to what is oftentimes promulgated in the literature, and something that has oftentimes been promulgated by Dr. Grossman, who's written the books On Killing and On Combat. And the thought is, the further you are from combat physically, the less mentally engaged or responsive one might be to the emotional challenges of combat. And so this theory has been pushed out there quite a bit. And so the thought is that, well, if you're 3,000 miles away from the combat zone, even though visually you're seeing it, therefore, because of the geographical distance, you should not experience the level of emotional reactions that typically others might experience. And so we embarked on a study, next slide, in which we evaluated individuals at their place. We went to their locations, their units, and we put them through very comprehensive, structured interviews to ask them about what their reactions were during, just prior to and preparation, during a weapon strike, as well as right after. And we identified individuals that had engaged in at least one or more weapon strikes that had known kills to it. And we tallied things such as their aircrew experience, the number of weapon strikes, duty position, also to include the quality of imagery, because a lot of people will assume that if it's high definition, you're at a greater risk versus a standard definition. And then we also looked at mission outcomes on whether or not there were near actual unintended casualties. Next slide. From that, we asked them to describe their emotions, the range of emotions, and what kind of cognitive attributions they were making that was the source of some of their emotions in response to what they visually were involved or saw, but also the mission they were involved in. Next slide. On slide 24, it categorizes things according to whether or not you had a long, a reaction that was short duration, less than 48 hours, or of long duration, greater than 48 hours. And this was a natural way in which the distribution of the slides, or I'm sorry, the data fell. It was a natural cut point between 48 hours or less, all right? So next slide. I think we should be on slide 25 now. Thank you. Okay, so what we discovered as people were beginning to engage in a weapon strike, there were clear elevations in autonomic arousal, both their heart rate, their respiratory, their breathing, very clearly observable. And when we asked people who cross-trained in from a fighter aircraft like your F-16 or your F-15 or even your B-1 bomber, and we asked them, how is your experiences as a drone operator in preparation for a weapon strike different from when you were in theater providing weapon strikes? And what they told us was it was the exact same. There was no difference in terms of the autonomic and physiological and mental arousal they experienced as a drone operator 3,000 miles away as if they were flying the aircraft in theater. They told you they couldn't delineate a difference between the two. And that's pretty important because a lot of, again, folks have said if you're 3,000 miles away and you're physically removed, therefore emotionally or mentally you will be removed as well. And we just did not find any evidence of that. Next slide. So this is the range of autonomic arousal that you typically, or folks typically reported. And what's interesting about this is that all the missions are recorded, both the vocalizations as well as the visualizations. So it's easy to go back and verify whether or not there was elevations and changes in heart rate and other sort of things based upon what we could observe and what we could hear through the recordings. Okay, next slide. Slide 27 is the range of reactions, an example of a range of reactions that people would have to the same strike. And this is where people got confused. Typically, if there's a weapon strike, we have a tendency to say, oh, I guess all of the emotions that you're going to experience are going to be negative. The act of taking the life of another human individual is very, very difficult. And as a result, we see that it's likely going to be followed with negative emotions. But we also found, and this is where folks got confused, is, well, how can I experience both positive, neutral, and negative emotions in response to the same event? Because on one hand, there was a sense of confidence, a sense of gratification, a sense of relief and pride and camaraderie, centered around protecting lives on the ground, protecting troops on the ground, but at the same time also feeling a sense of sadness for having to take the life of another human being, leaving a son fatherless, a spouse single now, or I think you can understand that they could see the connections that the individual would have to family relationships and the loss that would create. Okay, next slide. Slide 28. So when we started categorizing the responses based upon how long people indicated their disruptive emotions lasted, what we found is 20 to 23% of the total RPA population reported an emotionally disruptive response of long duration. Let me clarify emotionally disruptive response. What I mean by that is this is somebody who's saying it is affecting them socially and behaviorally. It has led to an observable or noticeable change in their overall demeanor. Whether they're becoming more isolative or withdrawn, or perhaps they're feeling just a bit more stressed out in general and having a difficult time regulating it, or perhaps it's changed their worldview or the view of themselves or even others in general. Regardless, they're saying that there is a disruption there to them that has changed them and led to some kind of departure from normality in their behavioral and social demeanor. Next slide. Okay, with Intel operators, and Lillian can speak a little bit more to this, what we found is that they had 41%, which is about twice the rate of long duration, but unlike the RPA operators where it ranged anywhere between 10 and 11%, 22% had unresolved. And what I mean by unresolved is that these are issues and changes that they are currently still experiencing today. Now, I've also wanted to make it very clear that moral injury was not an issue here. Moral injury, as you define it, and as it's typically defined in the literature, such as by Dr. Nash, none of the individuals met the criteria for moral injury that experienced disruptive emotional reactions. Okay, next slide. So I know we're a little bit limited on time, and I've gone over a little bit, but what I want to share with you on this is that what we discovered was there was no real difference between high-definition video imagery and standard definition video imagery. One did not increase the likelihood of a disruptive response. There was also no difference between those who signed up for this and were relatively inexperienced versus those who had cross-trained in from another airframe or aircrew experience. So there was no difference between such inexperienced and experienced groups with regard to the emotional reactions. However, what we did find is mission outcomes certainly increased the risk. So if you were part of a mission where you watched and witnessed acts of inhumanity or torture, and there was some level of civilian bystanders or military casualties, you were actually 4 to 8 times more likely to experience a negative disruptive reaction. What we also discovered is that long-term surveillance of enemy combatants prior to a strike did not increase the likelihood of a disruptive response. Rather, it gets right back to the acts of inhumanity and unintended civilian or military casualties. Now, what we did discover also, though, is that the sensor operators were twice as likely to have a disruptive emotion of long duration. Now, our sensor operators are typically between the ages of 18 and 24, whereas your pilots are between the ages of like 22 and their mid-30s. So perhaps there's a function of age and maturation there. Next slide. And so what we've done is we've actually put out a number of different recommendations. Here's just a few of the recommendations that we've engaged in with leadership all the way from the Pentagon down to the local units. But what our whole goal is to essentially educate providers on the realities and stressors and challenges that these individuals experience. And right now, I think a lot of myths and misperceptions are being promulgated not only by, of course, the media, but oftentimes with folks within the mental health profession that may not understand or realize the difficulties that even though these are individuals who are removed and are 3,000 miles away from the battlefield, they still carry a significant amount of stress on a daily basis. With that being said, let me go to the next slide. Let me turn this over to Ms. Prince for her portion.
All right, thank you, Dr. Chattal. This is Angela Wright. I really wanted to just take a moment there to thank you for your presentation, and it was fascinating. And Ms. Prince, I would like to turn it over to you and hear about what you have to say on this topic. Thank you.
Yes, thank you very much. Everyone, I'll be building off of the foundation that Dr. Chappelle has laid with regard to what we've learned about the RPA and related intel communities that we've studied. I'll be expanding in particular on our study information regarding this population, focusing on the health habits and trends, as well as the current healthcare strategies that are critical to addressing the needs of this community. Next slide. Next slide, please. Okay. All right, so based on the highly technical and extremely dynamic nature of the remote warrior mission, as was well explained by Dr. Chappelle in the previous slides, there's a great deal of interest in better understanding the operational, the occupational, and health factors associated with these missions. And that interest is across the levels of government, as you can imagine. In particular, these factors, some of the factors are broken out on the lower portion of the slide, so you get a sense of the kinds of areas of interest that we're frequently asked about. Now, our research methodology is designed to foster honest disclosure in this area from those who participate in an effort to garner ground truth in these areas. And you've heard quite a bit about the psychological impacts on this population from Dr. Chappelle. Next slide. Based on the aeromedical goals outlined on this particular slide, the first few have been covered, but if you focus on those highlighted in the blue box, you'll see that there are certain areas that we haven't yet touched on, and those are the ones that I'll be focusing on today. I'll be sharing with you the latest in physical and behavioral health outcomes regarding exercise and fitness habits, caffeine and tobacco use, alcohol use and abuse, sleep trends, as well as the medical issues and reasons and rates of prescription and over-the-counter medication utilization among this population. So at this point, we'll be rounding out our perspective on the health dynamics for this RPA and Intel population. Next slide. So when we take a moment to review the key sources of stress that you may be familiar with at this point associated with the remote warriors, we can see that interdependent nature of these stressors, and we can see that there's a direct manner in which physical health facets can be affected along with the psychological facets that have already been discussed. When comparing these stress sources to the reported topics of interest that you see sort of to the upper right portion of the slide, these personnel, it's clear that these personnel, they recognize the health strategies for which they may be in need of help or may need assistance in improving. And so we will focus, as you look at that particular box, on those highlighted in blue, the energy management, the mental resiliency, and the health habits as are reflected in the data points we were able to gather through our studies. Bottom line, what we'll be seeing is how stress is manifesting in terms of operational health trends. Next slide. Okay, it looks like the graphic has gone away here, but that's okay. What this slide should reflect to you is the current reported rate of aerobic exercise performed by the remote warrior community. Well, I would say for our RPA participants, we would be able to show you some breakouts there. But in the absence of the graphic, what I can tell you is that for both sides of this very dynamic career field, there are notable rates of diminished fitness activity. So you can see that among our Intel operators, our DGS operators, only about 35 to 44% are reporting the ability to engage in aerobic activity that is 2 times or less per week. And at a slightly higher rate, the 40 the RPA operators report engaging in that same level of activity. Interestingly, it's a similar percentage of operators who exercise slightly more frequently, but only about 16 to 18% are aerobically exercising the 5 days or more per week, which is what is consistent with federal physical fitness guidelines. So really the rate at which we can have optimal fitness. Considering the military community, we would want to see a greater degree of fitness activity in this population. Based on these numbers, at least 40% of the population are exercising or at a level that's inadequate to maintain this optimal fitness. Additionally, with this rate, they're failing to optimize on what would be a highly beneficial coping strategy for dealing with the stress impacts that you've been previously presented with. Next slide. On this slide, you see outlines the negative health effects of excess caffeine. Caffeine consumption is another method by which these operators may seek to stimulate their capacities to cope not only with stress, but also to increase their mental vigilance. So with diminished exercise, caffeine is a source to offset this shortfall. In our remote warrior occupational health reports, we share this particular side very specifically with our operational leaders to provide context to the caffeine utilization rates among their populations. Now, of particular concern as researchers is the elevated consumption of various energy drinks in combination with the standard caffeinated beverages such as coffee or tea or standard sodas that we've all grown up with. And the other stimulants because of the health risks that can come with excess use. So it's this combined use that is creating concern for which there's a need for more study. Next slide. So on this slide, which I believe is slide 39 for you, what you see are the actual outcomes from some of our more recent studies. So these are our most current caffeine utilization trends among the remote warrior population. And we see that about 80% report some type of caffeine use. Of these, nearly 20% report combined consumption of the traditional beverages, coffee, tea, sodas, with the designer energy drinks, with that, think Monster, Red Bull, those types of things. Of particular note, a similar percentage are consuming in excess of 5 caffeinated drinks per day. So even if these were all standard coffee, tea, soda type drinks, the quantity of caffeine with that number of beverages alone would pose considerable physical health risks and would also contribute greatly to the sleep issues that are known to plague this population. We're going to talk a little bit more about sleep trends shortly. Next slide. But before we get to that, here you're able to see in graphic form the degree to which RPA and our Intel personnel report increased caffeinated beverage consumption. Among the RPA personnel, which you see a little bit broken out in the graphic, approximately 50% report increased consumption since being assigned to this particular mission. Among DCGS Intel personnel, it's about half that rate, at 27%, but this is still more than a quarter of the population endorsing an increase. So keep that thought of elevated caffeine use and challenges of sleep in mind as we move to the next slide. As we continue forth here to this slide, what we see is the current rate of tobacco use. And here again, yet another source of stimulant and another consideration as we look forward to addressing the issue of sleep in a 24/7 remote warrior type mission area. Tobacco use among remote warriors is consistent with that of the general population, but we have to consider it additive to the other stimulants already reported. Here we see that a relatively small percent report increased tobacco use. A similar but growing percentage reports use of nicotine alternatives, though, e-cigs, vapes, that type of alternative. So this is an area of interest because of the unregulated nature of the product and the shortage of data on the health effects of utilizing these types of things long term. So while we see relatively normative data within our population to that of the U.S. population at large, there are other areas of research to be examined down the road. Coping with work and family stress and sustaining alertness are the most common reasons for increased tobacco or nicotine use within this population. And we'll keep these types of things in mind as we proceed forward. Next slide. So as we have rounded out the stimulant use, we'll take a look at alcohol as a means of basically winding down after all of that winding up with stimulant. Of the remote warriors, roughly 80% of those who reported in our study report some degree of alcohol use. Now, most of this would probably fall within what would be considered established norms of healthy use. However, approximately 20 to 25% report above normal alcohol consumption. And keep in mind, this is via open disclosure, so there may be some variability in range of what is actual truth. 4 to 7% report monthly binge drinking, which of course is associated with other safety risks and negative outcomes. So this, of course, is a key area of concern for the operational leaders who we typically provide feedback to with regard to the occupational health of their organization. These are the things that can not only create health issues for the individual, but create other issues for them in terms of their status within the military, their legal well-being, and so forth, as well as the health of others with whom they may interact. The average reported rate of increased alcohol use is most often attributed to coping with stress. Social interaction is also reported, and the need for sleep is always present. Alcohol is often reported as a means of initiating sleep among this population, especially those who work the 24/7 shift schedule. Next slide. So on this slide, here again, you see a breakout of RPA and our DGS Intel folks with regard to reported increase in alcohol use. It just gives you a little more granularity into the extent to which alcohol is frequently utilized by these personnel to manage stress and aid in sleep. Next slide. So, sleep. We've been talking about that intermittently along the way. Sleep is probably the number one issue that is reported by this population in terms of having difficulty in achieving adequate rest. It is a significant issue for most remote warriors due to their shift work schedule. And it can not only contribute to chronic fatigue because of the times of day that work is required for them, which may not be in the day at all. It could be way into the hours of the night, early morning. But it also can create challenges to achieving adequate quality rest based on when sleep is required. So that cycle of rest is always a challenge for these folks, and they're seeking effective ways to manage that cycle and be effective in their work environment. So on the previous slide, alcohol was cited as a means of self-treatment in order to induce sleep. Although, as health professionals, we know that it doesn't foster the quality of sleep needed for good health and can bring with it the risk of dependency. As you can see on this slide, over-the-counter medications are also frequently used to aid in sleep. About 20 to 23% report doing this. Prescription medication, to a somewhat lesser extent, is used for this purpose at about 8 to 15%. So while dependency is a risk with any medication use, the lack of oversight with over-the-counter medication as well as alcohol products can bring additional health concerns for this population. Next slide. All right. But sleep, it's not alone as the only significant health issue reported among remote warriors. Here on the slide, you see that headaches, eye strain, vision problems, as well as upper body pain, those together round out the most frequently reported medical issues exacerbated by the remote warrior work environment. Additionally, over-the-counter strategies appear to be more frequently employed than the prescription counterparts in addressing these health issues. Again, this may raise concerns for leaders and health providers on various levels, not the least of which is the limited ability to ensure appropriate use. Next slide. So, like the modest increase in medication use that we've just seen on the previous slide, this slide here, I believe it's slide 46 for those of you who are observing, this slide shows that utilization of health services has also increased among the remote warrior population in recent years. Now, while there's ample evidence of the need for medical health care, the increase in mental health care utilization elevates some concern, particularly in light of the negative psychological health impacts reported by Dr. Chappell earlier. The mental health and medical providers, who are at the core of what we call the embedded operational medicine element, are beginning to make strides in addressing these concerns, specifically in addressing remote warrior health issues by pushing care forward to those who need it, and in reducing perceptions of stigma, particularly associated with seeking mental health care or stress-related care. Next slide. So thus far, having reviewed the health habits and medical trends identified among remote warriors as were outcome of our most recent occupational stress studies, here we see a summary of our perspectives as health researchers on optimizing integrated health and resiliency strategies. Our goal is to foster the education of leaders and operators on healthy versus unhealthy habits. And we've reviewed an array of health practices which could go either way. Also, we seek to increase awareness of good sleep hygiene and other strategies to induce and sustain quality sleep, which is critical to overall energy management and effectiveness as operators in this particularly dynamic career field. We also seek to sustain a healthy focus on safe alcohol consumption as well as caffeine consumption to effectively manage the energy cycle for these personnel and to avoid dependency concerns. And above all, we seek to facilitate access to care in addressing the negative effects of stress, whether they be physical or emotional. Next slide. The architecture we have been advocating is one of comprehensive care, ultimately one that would be available across the active duty and into the total force. This slide offers a visual depiction of the kind of comprehensive embedded care strategy that we've been working to establish for our U.S. Air Force remote warriors and other critical mission personnel that previously have struggled with accessing care. This strategy that pushes care resources forward into the operational organization itself maximizes operator performance within that operational environment. Next slide. So the visual you see here on slide 49 is intended to provide further context to this comprehensive care model. So I'd ask you to look first and foremost at this sort of reddish box right in the middle at the core of the concentric circles. At USAFSA, we focus on strengthening the construct for that embedded provider component in particular. However, it is not alone at the core of what is evolving into a resiliency support construct intended to provide comprehensive resiliency care to operators who work in these kinds of environments. You see, if you go into the next outer concentric loop, that spiritual consultancy is part of that overall construct. So it's an environment in which we bring our health providers and to team with the chaplaincy for spiritual consultancy to provide a comprehensive resiliency opportunity for these personnel. Together, these care leaders not only provide embedded consultancy, but are facilitators of access to other care resources within the broader medical and base support community. And that brings you out to that outermost concentric loop that outlines the kind of resources available on most military installations. Next slide. So on this slide, slide 50, there are several graphics, and hopefully you can read them well, but let me highlight what they're meant to reflect. This slide shows the preliminary impacts of the remote warrior embedded care construct as determined from data received in our occupational stress studies. What we see from the data gained is that full-time embedded care can help to alleviate the key stress impacts within these populations. Satisfaction among those utilizing these care resources thus far appears to be high and indicates a greater degree of comfort on the part of these remote warriors with the utilization of embedded providers as opposed to seeking care through more traditional means. Together, these graphics tell us that by pushing care forward, we're increasing the likelihood of those who need care accessing it. Next slide. So on slide 51, we see some firsthand feedback from remote warrior operators and their leadership. This is perhaps the point along the way where we see the most contextual information about the impact of what these providers can bring to bear. And what we can tell is that the operational benefits of the embedded care construct is pretty profound. Not only are they starting to see improvements in long-term schedule sustainment, a key operational concern for 24/7 operation, but also in the overall readiness rates of the personnel who work there. So from an operational effectiveness perspective, these are good indicators to see. Next slide. But perhaps more importantly, leaders are beginning to see the emotional health benefit of readily present care resources, particularly in addressing mental health and emotional stress, and in reducing suicidal ideation and suicidal events within their organization. On slide 52, you see some of the direct quotes from leaders and operators within this community with regard to suicide prevention. Next slide. So to summarize, with regard to our efforts to better understand the dynamics within the remote warrior arena, through our surveys and interviews, we're using the information to pursue strategies that will improve the embedded provider construct. And in so doing, interest in how this can be expanded and improved is increasing, and the total force is beginning to see the strength of this model and is looking to pursue a similar path. Our hope is that through sharing the findings from our studies across DoD and through forums such as this, as well as through the publication of technical reports and journal articles on these issues of health, we may be able to extend the groundwork for continuity of care for remote warriors and others who work in similar critical career fields, regardless of where they may be on the status of service continuum, whether active duty in the total force component or in transitioning into the civilian sector. It's in this area where partnership with many of you who are participating today can take a part in helping this grow. Next slide. And that concludes my portion of the presentation. Hopefully the combined information shared on the occupational health studies will be of use to all of you, and we welcome questions.
All right. Thank you. This is Angela Wright from the SMVF TA Center. Thank you, Mrs. Prince, for taking the time to delve so deeply into your study and the behavioral health needs and looking into the tobacco use, the alcohol use, and trying to manage the shift work with all of those things. I appreciate you delving deep into that with us. I just kind of want to bridge a little bit right now. We're going to go into a question and answer session, and I'm going to turn it over to Xavier in just a moment. But something I'd really like to hear from Dr. Chappell, what do you think that these RPA operators might want our audience to know about them? Just as a thought question, what do you think that this audience should know? You had mentioned in some of your slides some quotes from the operators, and we kind of skipped over them a little bit just due to time, and we felt that those were really insightful and wanted to bring highlight to that.
Well, I think there's probably a number of things that the drone operators would want folks to know, and I really appreciate that question. And again, when I reflect on drone operators, I'm not talking about the ones that just simply manage aircraft that fly really high in the sky and take pictures and video, but the ones that, no kidding, have weapon capabilities and that are involved at the front end of the fight. And I think when I ask those drone operators, what would you like me to share with mental health professionals out there, oftentimes it comes down to three particular responses. One is just how stressful this is. Oftentimes what they see in the news or what they hear others saying is that because you get to go home at the end of the evening and you don't have to be separated from family, your life should be easier. And I think the drone operators out there would want mental health providers to know is not only is it not easy, but in some cases it actually can be more challenging and more difficult than if they were deployed. And I'll never forget when I asked this question about 5 years ago. I said, "Sir, what goes through your mind to kind of ease your stress?" And the individual says, "I think about deployment." And I asked, "Well, why?" And he says, "Well, because when I'm deployed, I don't have to worry about juggling my family obligations, my obligations to my spouse, my children, all of these things in my personal life and the expectations that people leverage on me. At the same time, I have to manage my warfighting role." And so what I discovered, and I think what drone operators will tell you, is that sometimes having to deal with a warfighting role simultaneously with one's personal life and domestic role can lead to a kaleidoscope of just stress. So I think they would want folks to know that. I think they'd also want folks to know that they are definitely at the tip of the spear, and they support troops on the ground, and that there's a real recognition to what it is that they're doing. And what I mean by that is I think they would suggest that, one, we're not just simply doing things from a passive fashion, but we're very much actively involved in the war. But we're also very much involved in joint operations in which we're communicating with ground troops, and we have a personal connection and a team-oriented connection to those individuals that are on the ground who we're supporting. I think that's something that they would want folks to know, because it's not a sterile environment. It's very much an interpersonal environment that they're engaged in. And I think the last thing I think they would want to share, and Lily and I, Ms. Prince and I have heard this over and over countless times, is that video games and comparison of drone operations to video games is not even worthy of discussion. And that's a quote directly from RPA operators themselves. A lot of times the general public assumes that a good RPA operator is somebody who loves video games, And what we discovered actually with our studies is that many of them have no interest in video games, let alone have time to play with them. So it is definitely not a comparing and contrasting the drone environment with video games is probably an insult to most of them. And I think it's a great way to not establish rapport by having that. And a lot of times people assume, well, gosh, if you do play video games and you're really good at it, then this would be a really good platform for you. And what we have found from the training cadre is that this is very much a very serious, I guess you can say, somber platform, and anybody who approached the training or the operations as though it was a video game would not be well suited for this environment because of the realities and the consequences of their actions. Does that help sum it up a little bit?
Absolutely. Thank you so much, Dr. Chappell, for giving us that insight. And I'd like to go ahead and turn over to Xavier with the National Council. He has several other questions that were posed by the audience, and I think he'll go ahead and take over now. Thank you.
Thank you so much. We've got a number of questions, and I just want to reiterate that we are trying to get to as many as time allows. The first question is directed to you, Dr. Chappell. And so a number of folks have been asking about how do these teams, the military drone operators, find positive outlets to relieve stress? Do they do this as a group?
That is a great question. They do it both individually and as a group. One of the things that helps release their stress is reminding themselves of how important it is what they're doing. So even though they're working long hours and it is a real challenge to try and juggle both the warfighting and the domestic life roles, one of the things that helps them get up out of bed in the morning and show up to work is the notion that they are protecting lives. And so just simply reminding oneself of the impact and the importance of what they're doing can actually help decompress some of the stress they're experiencing. But other areas that we found particularly helpful is embedding mental health providers. Ms. Prince brought this up a little bit earlier, but having somebody that has an appropriate top secret security clearance that has their office in the classified setting gives that person the opportunity to sit down and share or express themselves. So for instance, if they have finished up with a weapon strike and they're going, I'm really kind of anxious about what happened and sad about what happened. Does this make me non-suited? Well, in many regards, these are very normal reactions, and we would be worried if people didn't have that kind of reaction. But the RP operator may not know that. So one of the things that helps decompress their stress is being able to have carte blanche access to a mental health provider that allows them to simply vent and express their emotions, their experiences, and to experience a sense of validation. The other piece that helps decompress their stress is mental health providers giving outreach to the spouses and the families. See, sometimes spouses and families can have unrealistic expectations about the stressful environment itself, oftentimes basing their own assumptions on what they see on TV or in the movies. And as a result, they come up with very unrealistic ideas about how stressful it is and may not understand why the guard or reservist or active duty member comes home after a shift and is completely spent. So one way is to help bridge and train families about the realities of the stressful environment, and then ways to maintain strong relationships underneath stressful environments. So that gets down to the communication and rapport building and so on. The other part was, can they do this as groups? They can, but that's a real challenge because these are oftentimes long shifts that they work, and so as soon as they're done with the shift, I assumed that their anxiety level would go down, and we actually have done this where we've surveyed anxiety pre-post shift, and what we discovered was the anxiety was going up. going up. And what we do is we ask them, well, why is your anxiety going up now that your mission is over? And they'll tell you it's because I got to go home and I got so many things that I have to juggle. So unfortunately, at the end of the shift, most of them are taking off, and there's not really enough time for them to engage in camaraderie or rapport-building activities as a group.
Wayne, if I may add to that.
Okay.
Certainly, please go ahead.
Hi, I'm sorry. This is Lillian Prince. I think that you touched on such important issues, and one of the things that when we present to our operational leadership about our findings that we try so hard to emphasize is, to the fullest extent possible, considering these challenging dynamics in terms of resiliency and decompression time, is with our leaders to foster strategies for cohesion building within the organization to whatever level is possible. So giving these leaders an opportunity to consider ways in which they can create opportunity for collective gathering, which is a challenge, or have morale-building activities at times that will accommodate the shift work times, for regardless of what time frame that may be around the 24/7 cycle. These are the kinds of things that we encourage to our leaders, because we know it is a challenge for these operators just inherently to be able to have that decompression and that morale-building opportunity otherwise. So
yeah, let me add in.
Mm-hmm.
Let me add in one thing in there, and that is something that we discovered. And everybody always asks, well, as a mental health provider, what can I do to help reduce the incident rate of medically significant distress or problematic alcohol use or sleep-related problems? And what we've discovered is those units that have even though they have the same mission, the same limited manning, the same long hours, etc., those units that have stronger levels of cohesion and morale have a lower incident rate of those sort of conditions. So ironically, when we think, well, what's the best way to do outreach for these individuals, our hip pocket oftentimes says, let's go out and do some suicide prevention briefings or alcohol misuse briefings, when in reality, it's training the commanders and the operators how to maintain a strong, cohesive environment. And what would that look like? It would also include post-mission socialization, where after the mission is, you've built in enough time that you can go back, sit in what we would call the heritage room, and give yourself time to just decompress with your peers.
Great, thank you so much. The next question is for you as well, Dr. Chappell, and it reads, how are we dealing with the negative implications or consequences of the perception of the service member's ability to perform duties with self-disclosure? I think maybe another way of positing the question could be, certainly there may be some service member ambivalence about coming forward if they suspect that they may be struggling with a behavioral health condition. And certainly they may have a perception that self-disclosure could negatively impact their career or their duties. So how might a provider address that concern?
First of all, I think it's a very real concern. And the concern that RPA operators have about self-disclosing mental health problems and the concern it might have on their career is not a new phenomenon. It's something that, for me as an aeromedical psychologist, I work with air crew and special duty operators from a wide range of different units, and they all share a very similar concern. I think the first thing to do is to validate it, because some of their concerns are very real. For instance, if you go see a mental health provider and the mental health provider says, hey, guess what, coming and see me is not going to hurt your career, it's only going to make it better. And then that mental health provider say, hey, look, if I diagnose you with an adjustment disorder with depressed mood, it's not going to remove you from your duties. Well, that's true if the adjustment disorder is less than 90 days. The person walks out the door, the mental health provider diagnoses the person with an adjustment disorder and says it's been ongoing for 6 months. Now the person is automatically deniffed and removed from duties. So there have been real incidences out there where well-intentioned, well-meaning mental health providers have given the same spiel that coming in and seeing them is going to be okay and better and won't hurt their career, but they lack education in aeromedical policy and the neuropsychiatry standards, and as a result end up creating a situation in which a person is removed and now it's jeopardized rapport. So I think the first thing is to validate those concerns because they are real. The second thing is for the provider to make sure that they understand the aeromedical policies that these RPA operators are held to. And simply just pulling out medical fitness for duty standards is not adequate because we hold these people to a higher set of standards than we do others. Very similar to, like I said, the air crew and special duty operators. The other piece to this, though, is also to let them know that you're not just there to mitigate or help somebody overcome a specific problem, but to help enhance their performance. See, in our mind as mental health providers, we think that our role is to simply help somebody mitigate symptoms of an illness, but in reality, the same skills that we have can be used to help a person obtain optimal states of functioning, more superior states of health. And when conveyed to RPA operators or air crew or special duty operators in general, that you're not there to just simply patch them up and send them back out the door, but to make them better than what they were before, that's very appealing. To include helping them not only succeed as an RPA operator, but helping them succeed as a family member. So does that help answer that question?
Yes, I thought that. Thank you so much. That was a very comprehensive answer. We appreciate it. The next question is, and I'm reading it again verbatim, does the VA or military clinicians provide tools to deal with hard issues as well as medications that can mask the problem rather than address the problem? So I would sort of maybe reposit that as thinking about sort of what are the tools which are available to clinicians both in the VA and in the military that can sort of help address any behavioral health conditions that might arise in military drone operators?
Yeah, I'll take field that one. And I think the question has two parts of it. Are there things that we're doing as mental health providers that mask the problem? And are there things that we're doing that help people adapt to the platform? And so the first part is, are there things that we're doing that can mask the problem? Absolutely. If somebody comes in and they're really depressed and anxious and we throw at them antidepressants or sleep medications, we're not really getting to the source of their problem. And so in some cases we have to make sure that what we do doesn't mask or just simply prolong the person from getting to the root of the problem. The other thing is also making sure that we're aware of just how much of an impact our mental health strategies can have. So for instance, you can do all the counseling in the world and really help a person achieve a higher state of psychological and social or emotional health, but if they're constantly rotating shifts every 30 days, you have to understand you're going to have a limited impact there. So it's also understanding just there are certain things that we can't correct as mental health providers that are more on the line military commander side of the house. Now, are there certain tools that we can use to help people get better? Yes. There's a lot of stuff that is common sense to a mental health provider that is new to RP operators, and this can include sleep hygiene, healthy sleep hygiene habits, healthy use of caffeinated beverages or energy supplements, appropriate exercise and healthy exercise habits. So simple behavioral things that we do on a day-to-day basis to cope with stress, we oftentimes as mental health providers might take for granted what we know is healthy and normal and not realize that RP operators, what they're doing may not be healthy or normal. A good example of this is when we asked the folks who were consuming 3 to 5 energy beverages on a daily basis, hey, do you realize what the impact is? and oftentimes they didn't understand the consequences of the substances that they were consuming on the various systems of their body and how it would lead to other kind of disruptions. Other tools that are available for us is that we're really good at validating people's emotions and helping them process their experience. One of the things I mentioned earlier is that these guys will walk out and they'll go, man, I had no idea one can have such a kaleidoscope of emotions to the same kind of conditions. And so helping people recognize, process, validate, and work through their emotions and the underlying attributions to those can be very, very helpful.
Great, thank you. This question also goes to Dr. Chappell. One of our participants has noted that the recommendations all seem really good for when you're dealing with a service member which is on active duty, but how do we take care of those who are enrolled in the Reserve or the National Guard and are called to active duty for periods of time and then go back to their unit once their orders are up?
Oh, that's a great question. And I just want to emphasize whoever asked that question is really forward-thinking because, as Lillian mentioned, this is a total force perspective, and that means we have to rely more and more upon our Guard and our reservists to be able to fulfill this particular mission. And so the growing number of people who will do this for a temporary period of time and then go right back to their traditional role or life is increasing. So we don't necessarily have the resources to embed people within the Guard, only to know that it's a temporary period of time. So I think one of the best things to do would be to advertise, to develop a peer or at least a professional network of mental health providers who are very familiar with RPA operations, who've consumed the research literature and are understanding of the issues and the stressors of that environment. Having a really good solid network of mental health providers that understand the platform is extremely helpful because then they could serve as a referral source. The other piece of this is then advertising those mental health providers to the Guard units so that somebody can be there who's perhaps on orders for a while, but they recognize that when they leave, there's a list of individuals that they can go to would be really helpful because right now those Guard and reservists don't know who to go to. And they could go to the VA and assume, well, because the person's at the VA, that this person may have some background or knowledge about RPA operations and realize, well, the person doesn't have much at all. So educating them, first forming a VA/civilian provider network, and then two, educating those folks on who those individuals are, I think is key.
Wayne, if I may, I have something just to add to that thought for the person who asked this question. As a reservist myself, I understand what it is to be in that position of going from civilian sector on duty and for occasionally having a health issue that might require going to the clinic. And sometimes just that process comes with its own challenges of getting care and then moving back into the civilian sector. What I can tell you specific to this arena is that the Guard and Reserve are increasingly more aware of these issues through the information that we've been sharing from our studies, but they're starting to think about ways to address that. So the Guard is looking at strategies. Of course, it's going to take some time to build that construct, as is the Reserve. At a meeting I was at recently, there was talk among the Reserve component in the health arena of utilizing healthcare providers who are IMAs, so Reserve augmentees, in these capacities and in considering how they might be placed in a similar way that our embedded providers are within the active duty, being placed forward in reserve capacities to sort of parallel the approach that's underway in the active side. So perhaps in the future there'll be mechanisms to facilitate care among those who are knowledgeable about the mission, as healthcare providers. But to sort of address that continuity of care challenge, there's still gaps there, and that's something that I think collectively, we'll be seeking to address as we proceed down the road with forward care to operational personnel, whether they're active duty or total force.
And part of that includes educating congressional leadership, folks who actually control how federal spending is directed and where it should be resourced is part of the battle, especially for outreach to the Guard and Reservist. And some folks might benefit from knowing is our goal when we do these things is to actually meet with congressional leadership so that they're informed about the requirements and needs of this community and then are in a better position based upon the information provided to allocate and direct resources.
Wonderful. As we close today's webinar, I just want to thank you so much to all of our presenters for offering their insight and expertise, and thank all of our participants for attending today's webinar. SAMHSA Service Members, Veterans, and Their Families Technical Assistance Center presents Understanding and Responding to the Emerging Behavioral Health Needs of Military Drone Operators. Once you leave today's webinar, you will receive a survey on the presentation, and we'd really appreciate it if you could complete that and provide your feedback. You will also receive a follow-up email by the end of the week with a link to view a recording of today's webinar. On behalf of the National Council, Policy Research Associates, and SAMHSA's SMVF TA Center, I'd like to thank you for joining us today, and please enjoy the rest of your day.
Awesome. Thank you.